very good afternoon to all. Welcome to the IC on iBanking, iDonate, iBanking and more. So in this session we'll be covering the different aspects of iBanking. India is an almost sufficient category country as far as iBanking is concerned. iBanking not only involves collection, processing and distribution, but there are other tissues that are also distributed such as the amniotic membrane and the sclera. And it involves engaging with the community, creating awareness and creating a motivation across all sections of the society to come forward and contribute to this task. In this session I am joined by Dr. Sujata Das, Dr. Manisha Acharya, Dr. Sunita Chaurasia. May I invite them to the dais, and we'll start with the first talk. Okay, is this better? Okay. So with the first talk of the session, Dr. Sujata Das, creating a model iBank.
Okay, good afternoon. It's not going. Okay. So this slide, most of you have seen. I always feel pride to show this slide because although the blindness is very high, but India is highly ready for cornea transplantation. Again, this slide also was seen by Sunita, maybe the last presentation, and Arvind spoke about that. India is almost sufficient. So iBank, we not only for cornea transplantation for restoring vision, is for research and education. But I did not realize that research as a they don't want research, many people, because they think it's for education, it's not for research. So iBank has two sections, like administrative and medical section. Normally administrative section deals with fundraising and liaisoning in public awareness program, and medical section with the harvesting, evaluation, preservation and distribution. In addition to this four, now tissue preparation has been added, and there is a shift in paradigm, shift in iBanking. We give emphasis more on utilization. Initially it was on collection, and we have moved from moist chamber to intermediate corneal storage solution. And morning we saw a presentation, we are thinking of long-term preservation rather than intermediate. And still people think why cornea I charge is charity model, but to iBank to sustain, it should be a self-sustainable model. And as I mentioned, expansion of functions like dissect and demec role. So models, there are different models. In Western countries, is mostly autonomous organization. They have their own board where stakeholders are from the community. But whereas in India, it's mostly attached with hospital. But there are in India also there are iBank which are autonomous organization. And either it is autonomous or associated with hospital. Most of them are learn and get the cornea from HCRP. In HCRP, again, the source are mostly from mortuary, and inpatient department, ICU contributes to less. Yeah, like source of tissue, it can be voluntary. Also, what is the percentage across our network? But there are places where voluntary is more. I don't know what is the ideal distribution between voluntary and motivated. Again, from HCRP, we get from ICU, ward and postmortem cases and other iBank. So when Dr. Rao proposed, it was 50% from HCRP and 50% from eye donation center or voluntary. So this is 5-year analysis of collection from our iBanks in 4 places. This is motivated tissue collection, and this is voluntary. So this is mainly important. You can see the last 5 years, the voluntary thing is 6.8 to 44. So it is different in different places. Maybe the awareness is more, although TKV is younger in term of establishment of iBank compared to DDEV, like Drishtidan iBank, which is in eastern part. So you can see 6-7%. Although I was very happy initially because the utilization was very high in our place, but gradually due to the issues with the different hospital, especially if you don't have a in-house source, like postmortem or ICU, it is a standalone eye hospital, then there is always a issue. Maybe it depends on the head of the organization, head of the FMT department. So gradually, maybe to have, we should not completely dependent on a hospital. We should have multiple source. So similarly, voluntary also should increase. I did not calculate what is the utilization, but all of us know voluntary utilization is less. We should be more dependent on SCRP, but not 100% dependent on SCRP, because it will gradually, suddenly your collection will dip down, it will be affected. I can give an example where in a medical college they stopped us for a small issue, and now we have gone to a district headquarter hospital. And district headquarter hospital, we are able to compensate whatever we are getting. Only thing is you have to plan manpower, because you cannot have two people. Morning somebody was telling in one state there is a that you have to have two eye donation counselor, which is practically not possible, because in district headquarter you don't expect more. It will be to have self-sustainable, maybe 10 to 12 utilization per, but so you have to manage with one person. So all of us know then why we choose SCRP, because of very good utilization, because of young donor, we got the history, death excision time is reduced. Hardly in our eye bank anybody has to go really from eye bank. Mostly they are there, so we don't get a call. In fact, we have a number, but we don't get a call because they are there. Except voluntary, we don't get. So we choose where the mortality rate is high. Again, surprisingly, most of the SCRP in all places from government hospital. Although education looks like education has nothing to do with the donation, most of the poor and uneducated person donate easily. Maybe the death rate is less in private hospital, or the people die due to septicemia, which are the contraindication cases. So mostly we get from government hospital, and we know SCRP is dedicated counselors we need for that, and it's a good idea to have technician come counselor rather than only counselor. So what are the advantages of voluntary cornea collection? We are less dependent on any hospital, and we develop a goodwill in society. Again, it creates a message. And voluntary organization, you are dependent on community leaders, many NGOs, self-help group, but only there's a limiting factor I can say. Sometimes they're over enthusiastic, they call you from a distance which is 200 kilometers. They need to know the limitation of the eye bank. They cannot go beyond that. Eye bank has to decide depending on the road. So in our place, I just keep 50 to 60 kilometer radius so that people can go and collect. So this is again proposed by Dr. Rao way back in 2004. It was published. Each eye bank has 20 million people and 40 eye donation center for each eye bank, and each are HCRP in 10 major hospital, but 10 major hospital may not be there in all places. There is no rule as such, but ideally there is no need of one eye bank in each city. So we can have a high standard eye bank if we have a one eye bank, and people can distribute from this. And we need to have expensive infrastructure, because with the technology people have pre-cut machines, so this increases the efficiency of standard. So why you were talking about certification? Because one was certification, one was model, one is certification. To result successful graft, at the end of the day we want a successful graft outcome. So quality control is a part of quality assurance. So this is quality assurance and quality control. So what we do normally, I'll just tell the name and I'll show few pictures where the quality assurance is done. Usually a medical director and eye bank manager, there should be SOP. First of all, there should be SOP in each eye bank. Review of donor records. Some people do 10% of the collection. You can decide whatever you want to do, either 10%, 20% in a month or 2 months, but that should be written in the SOP. Then adverse reaction, most of the time cornea surgeon forget to report it to eye bank. We don't get adverse reaction report, because as it like endophthalmitis, I always say it's like endophthalmitis. Eye bank manager, everybody should be alert if it's adverse reaction, and immediately you should do tissue recall and withdrawal, either in the adverse reaction, or if you know the cause is not. Sometimes you get postmortem report and the tissue cannot be used, the tissue recall and withdrawal. Anything deviation, non-conformance, and CAPA, corrective action, preventive action, all are like NABH, but many hospitals are not NABH, but eye bank can do all this. Internal auditing, again from somebody from this hospital, other department, they can do internal auditing. And external auditing, Site Life does for few, but EBI and NABH has a plan to do external auditing. Then environmental monitoring is, this is UV light, again you keep culture plate to know, it's like OR. If you are doing pre-cut, even if you are not doing pre-cut, environmental monitoring is required. And any investigation anyway, it's a NPCB requirement. We do investigation, positive serology. Again, it is written that not to be used. So this is the format we use for donor requirement. Anything is a major or minor is divided, and what action you take for that. This is example of adverse reaction. You can see this is immediately after surgery. So corneoscleral ream culture is not part of the process in most places, but ideally it can be kept. This is not a big thing. It can be kept for 2 weeks. In case patient develops, within that we can send the corneoscleral ream for culture. Most of the time it may be probable, but if it grows same organism, then it is definitely most due to donor related. Although it is sent to surgeon outside, but most of the time we don't get back the form. This is culture plate kept in laminar flow hood, and this is the UV light. This some of the, because otherwise you write the refrigerator also, and continuous recording temperature and the fridge is requirement for many accreditation agency. Thank you.
Thank you, Dr. Sujata. We'll take the next speaker, Dr. Manisha Acharya. She will be speaking on corneal tissue evaluation, suitability and contraindications for acceptance.
Now maybe that continuous recording to the graph one or the other one? No, not the G probe one. So with the other one, recently we got the refrigerator, I was asking. That is a sensor, it gives when you are at the can you just share with me, because we have to buy for an eye collection center so we can.
Yes, yes, Mike.
Mortuary related corneal retrieval program like a MCRP.
Yeah.
Because MCRP also almost 99% in a BD we get from here also it's around 70%. In some places the mortuary is a part of hospital, some places it is not. So that is why so it's more like a hospital affiliation. We may have hospital affiliation itself. So rather than terminology wise it's basically the same thing, but then just to highlight, I think that is important.
One of the reason is mortuary directly sometimes, most of the road traffic accidents, they are very young, the donors.
Mostly from mortuary. RD we get from what? This in Mushtidan, RD like 99 I say from HCRP mainly is also like this, apart from the tests which happen in the ICUs and other places, wards and all, it's mainly from the mortuary. I think the useful cases are just in CCU, otherwise all are contrary. I can relate to that. We also have.
Right, if you actually look at the data, RTA related accidents, so every year there are 90,000 plus, and most of them, 90% of them under 30 years. I think if all major cities, if we have something like that, I think our need is easily taken care. We don't need a much effort. No, but this needs a legislation. There are certain, roadblocks.
In the EBI session.
Create individual problems for in some places like individual states come up with those issues, but if we have a kind of a proper legislation law, it will not create a problem. So I think that is what was being discussed in the morning EBI session also.
Yes, that's the bottleneck that many medical legal authorities do not allow access to the victim before the postmortem has been conducted, and many a times and also all over India there is a legislation that postmortems cannot be conducted in the evening or at night. So at time we lose the valuable time by which we can retrieve the tissue. So these are some of the bottlenecks, but I think that apart, the best quality tissues and also the most young donors, unfortunately, they are in this category where they are victims of road traffic accidents or other medical legal incidents, and those tissues can be best collected in a mortuary.
So when we all are agreeing that mortuary are one of the most important places that which can yield good quality tissue, I think one of the other bottleneck comes is that you need a police permission. I don't know about that. So
Yes.
I think sensitization of policemen is important. I think this year, I mean, we are having that as a theme for our eye donation fortnight, that we are trying to go to Delhi police and trying to, because in their curriculum, they are never taught about what is eye donation and how their contribution is. I think we all started from HCRP, but most of the eye banks are very dependent on mortuary. And I can just give one example. During COVID, when it was peak, we have one eye collection center in Vrindavan and a little apart from there. So that was more like a rural area where Delhi was at peak, that was not at peak. So the system keeps on moving if you have it. And there that mortuary was at the highway. So like 90% was road traffic accident highway. That is the fastest highway which is there, and usually there were road traffic accidents. And I would say that is what kept that main wave, the second wave. Maybe never had at least one or two tissues were coming to take care of that dire necessity sort of patients. We were able to, I mean, we hardly use glycerine. We were able to take care of those emergencies. And so I think, but the only thing which I realized that even now HCRP, we started with HCRP and we were getting decent. Now this is an easy thing. Even for counselors, they know where to go. And at one place, they will, even if you try to send them to wards, the first thing they say, we won't get. So their outcome is not that. The effort is more than the outcome. I'm not saying HCRP is not, it's not a good place, but I think somewhere it's more like mortuaries are an easier access and all. But I think there are two things what you said. One was that post-mortem, should it, I mean, I've been trying to counsel and personally went to mortuaries and trying to counsel them, let us take eye, we can take eye before post-mortem, but most of the mortuaries are very reluctant. It's very dependent on which person is posted there.
Yes.
Because that's something, and that's more important, because they would say wait for 2 hours, we'll do a post-mortem. And sometimes if there's a new person, wo pura instrument rakh diya aankh pe. I mean, you know, these are some things which, and you think it's just something, but I think we need to sensitize. Yes, ma'am.
Is the eye donation considered as tissue donation or organ donation?
Right now it comes under HOTA, so
Organ
it's in organ donation, but it's I mean
Because if it is under tissue donation, then they don't really need to wait till the postmortem.
they don't need to wait for the post-mortem, but it's very dependent on which person is posted there. You know, that's what I'm saying. We did a study recently, that thesis part was when we are taking the tissue with before post-mortem and when we are taking after post-mortem, what is the difference in the quality?
Maybe the ophthalmologists need to unite on this and make because I would be like a tissue donation. So if they make it under tissue donation category, then it should be allowed in all over India rather than have so many different rules for different states.
We had policymakers in the first session of EBAI, and the same thing was put on them also.
Actually, the
But
problem is
everybody
that
of the same, this is
in the
very
policy
straight
making,
effort.
ophthalmologists are just one part. It is
Yes.
they're just, and they have just probably less than 50% role in making the policies. Predominantly, the policies are made by other people who are non-ophthalmologists, and where it is difficult to form a common understanding platform to make those policies. That is the basic crux of the problem.
And when we are talking about unity in ophthalmologists, you see the eye banking response. So people are usually not there who can actually change something. We are still trying our best. I think we are there, who are pushing these things. And in the first session we did, there was a lot of talk about it, but I think that's a very good valid point. We all should do it in our region, whatever we can.
Thank you.
Yeah, that's very important.
Yes.
Yes.
So thank you, Dr. Arvind. And Yeah, OC, for giving me this opportunity. I think Dr. Arvind had beautifully emphasized what is to be done in this instruction course, and I'm very happy to be and privileged to be part of this. So I'll be discussing a little about cornea tissue evaluation, the suitability and contraindications for acceptance. So what do we expect when a tissue comes to us? We want a better donor cornea utilization rate as an eye bank, a little balance in demand and supply. The quality issues should be met whenever we are doing it, but there are definitely much greater expectations from the surgeon's point of view as well. So when we started, the tissue actually comes to the eye bank, and then when it reaches the eye bank, you have to go in for evaluation. So how does that start? Earlier we were evaluating, I mean, a lot of us can relate to it. It used to come to the OPD, and we used to shake it like this, and we were evaluating in the OPDs. But nowadays we have this evaluation stand, and the entire evaluation is now done in the eye bank only. After the tissue is done, we've done a slit lamp evaluation. The other thing which is done parallelly or later is the specular examination for the tissue. So once we've done that, only then we say that the tissue is ready for distribution. But how does this process go? So we need to understand that the tissues have to be distributed for maybe a full thickness keratoplasty or a partial thickness, or these lamellar procedures, which may be an optical or a therapeutic tissue, or for DALC, DSEC or DMEC. So one thing which is important is the donor characteristics. So once it's in the eye bank, we are presuming that the contraindications for retrieval have already been taken care of. So what becomes important is the donor age. We know that there are a lot of studies which say that the graft survival is independent of donor age, but most of the eye banks are taking it 2 to 80 years as one of the age where the donor tissue is accepted. And I don't think 80 is something which is sacrosanct, but as an eye bank, most of us have done internal studies to say that the utilization beyond 80 becomes a little reduced, and so as a take home, I would say that age is particularly no bar if it's particular eye bank SOP which is important. But there is constraint of using an infant cornea because they are smaller diameter, they're very elastic, just to punch out of them is not very easy, and they're pretty thin. Death to excision time, again I would say most eye banks have their own acceptable death to preservation time. It is very important of where the eye bank is located. So it's in very hot areas, you may have to restrict it. Like in our eye bank, we have different DTPs depending on the season. If it's summers, it's 6 to 8 hours. If it is winters, it is up to 12, because winters is real cold in Delhi and around. So most eye banks usually accept 6 to 8, but that is very dependent on where you are posted and how the mortuary is. If you have a good mortuary with good system, even up to 24 hours is acceptable. Serology is very, very important. It is mandatory by law. Currently, a distribution can only be done after we get a serology physical report for HIV, HBsAg and VDRL. Again, what becomes actually the decision-making factors for most surgeons I have seen? It's basically the age of the donor, what they look for, the endothelial cell density, and sometimes even the lens status. These are the three things most surgeons ask. And we as eye bankers understand there is much more to the tissue than just these three things. So, I still believe that slit lamping is one of the major criteria wherein a rejection or wherein the suitability of a tissue should be seen. Tissue grading can be done as excellent, very good, fair, and not suitable for surgery depending on the type of tissue. So again, slit lamp biomicroscopic examination is the single most important step in donor corneal button evaluation, as it assesses the viability as well as the quality of the tissue. The outcomes is very dependent on the accurate biomicroscopic examination. So the different techniques for a slit lamp evaluation of the tissue are diffuse, which I showed first, then a narrow slit or optic section, a wide slit or a parallelepiped, a specular reflection and retroillumination. These are very easily now done with the normal slit lamp in the eye banking. But so that's why we all have come to the conclusion that very well trained optometrists become the best evaluators, and we are fortunate to have one in our as one of the eye bank managers for us. So if I go from layer to layer on the cornea, the epithelium can be clear and intact, or it may have haze, exposure, or sloughing. We have to differentiate when we are dealing with an epithelial defect or a sloughing which is there. So this is, the first picture is like a total slough which is there. It's just not there. And then these are the epithelial defects wherein the entire epithelium is now sloughed off. For the stroma, you can have a clear compact or an edema. So I would just go in for some pictures which you would like. So it can be a mild edema, it's more pictorial I would say, wherein you see the width of the slit is a little more than what a normal cornea would look like, but I would classify it as a good cornea. Or you can have some moderate edema, even focal moderate edema, where you see one area where there is a DM detachment, very focal DM detachment, and that area is sometimes more thickened. Sometimes you have such diffuse edema and DM folds which are there. We know that this quality tissue may not be the best, and you may not get any good specular count for them. This is one of the pictures wherein there was a LASIK flap which is very beautifully captured here, along with diffuse endothelial, I would say DM folds also which are present, along with bad surface as well. This is post-RK cornea. This is how the surface looks like when you see it. Most of these findings are best seen when you're doing it more like a coaxial retroillumination. Here, retro is not going to come from the fundus globe, but from the media it usually looks like this only. So it looks pretty good. So sometimes there is a scar which is there. So if you have a scar which is in the periphery, I mean, doing a good slit lamp examination and understand what's the depth of the scar is important, because superficial scars, if you want to take in for a desec, it's pretty good for pre-cut. But if you have a scar which is very thinned out at a point, you may get a perforation if you are trying for a desec. So understanding the depth of the scar is also important. Second importance for the scar, I would say, is if there is always a chance that it might be a herpetic scar. So those herpetic scars, if you're going to transplant, may lead to infection in the recipient as well. So these are the two things as clinician you want to know if there's a scar. If there is not much dearth of tissues, it's better not to use scar tissue, because most of the time you cannot pinpoint why it happened. So sometimes you have these infiltrates which are there, and this is basically WBC which accumulate in the cornea as inflammatory process to infection, which this may be present just before death only on the eye. It may also come up after that if it's in a mortuary or the eye has remained open for a long time and had led to some superadded infection. So they can also have it, but whenever we are seeing an infiltrate, it is best not to use the tissue. The most important thing whenever we are evaluating, especially an infiltrate or any other way, even if it is a scar, is to see the color of the media. It's very, very important. If there is any change in the color or you are having any suspicion, send the rim for cultures. And for these long-standing storage media, it is better to distribute after you've got the culture report of the rim, or just cut a section of the rim and plate it on bladder guard. This is very routinely when we are doing, whenever we feel there's any problem. So you can do that and then only do it. Descemet's detachment is something, if you're not a very trained evaluator, sometimes you miss. And if it's a very compact cornea and you've missed it, during surgery it becomes very difficult. You may have a primary graft failure, because the cornea looks pretty compact if it's just happened because of removal and you've just done it like that. Here if you see, the cornea is not looking very bad. And if you've not had an eye to see this detachment, you may put it like a good cornea. So it's an important sign. You may have just localized DMDs, because they may have compact corneas and they would not look like they cannot be used, and they're usually young donors. So we need to catch these points. Then comes an important point. Like, I have a lot of discussion with my manager on stress lines. They are very particular about stress lines. You have stress lines and they would put it as a therapeutic 25 years. Then you have to go back and say why 25 years is a therapeutic. And you're getting a decent endothelial count, but they are just not budging. No, stress lines are a no-no. So there are linear opacities at the endothelium, generally due to a rupture. These are the lines which usually come when you have a new technician who's retrieving, and somehow at the point when you are like lifting it up, there's somewhere bent has happened and these come up. So it's If you have a lot of stress lines, then again what we do in our eye bank is immediately call the technician who's done it and ask what is happening. Sometimes they have these good reasons when they say it was such a, like it was, we had to go at home and we couldn't do the haldi tha and all that, Indian scenario mein, there are a lot of other factors, we didn't have even a place to sit, so it's very difficult. You can't help it, but you have to train them again and again that this should not happen. So severity of stress lines can be few to several, several or numerous. So again you see this is how the stress lines look. If you look at this broad beam, behind that the endothelial per se is not there, but these are stress lines which will eventually damage the endothelium. Cell dropouts are important. These are loss of endothelial cells. If you are a good evaluator, you can easily capture these pictures. These are all our eye bank pictures. So you can easily capture these pictures, and this is the location is important for the cell dropouts. If you have a lot of cell dropout in the center, you would not pick it up as a good quality tissue. And this is the picture where you can differentiate on this. This is what we've put from our in our eye bank. This is what you call as mild, moderate, very severe, and this is the coaxial, and this is the just a side elimination. Rim is important because now a lot of lamellar surgeries are happening. You're happy with the larger 2 millimeter rim, but irregular rims are very common. Howsoever you tell them to use Trefine, sometimes they just don't use it and they say it's not possible, or they are not able to get to that right plane. So once you've evaluated the slit lamp, the other important finding is the specular microscopy, which you have to do. I always prefer to have these pictures which are now attached to most of our distribution sheet which we give. So there's this picture which is there which tells you exactly what is the CD and the other values for this specular. So once you have that, and if it is above 2000, and then you know that you can use this. Above 2500 is something you are happy about, along with good slit lamp findings. So this is the entire gamut of what you get, and if you now after this have the serology report which is negative, then you can actually distribute it, and this is the distribution criteria or the suitability criteria for the cornea which we follow in our eye bank. And I would just take you to a case where the donor was 28 years, the cell count was 2820, but there were few to several stress lines with mild to moderate dropouts. And these are some cases where what I would just ask that what would you grade this as? So when I was part of that webinar where this was presented by our manager, and I was the one who said, I think we can use it for optical, but all the other evaluators who were non-doctors, non-surgeons, they were just not ready to say, no, there are several stress lines. We would grade it as therapeutic. It's up to the surgeon you want to use it. So, that is the difference sometimes you get, because they are now more trained, I would say, than us when they go into the great nuances of how we do it. So, because these were the pictures, this is what the entire case is like. These are the cell dropouts. So, so with so much of cell dropouts and stress lines, better not use it as an optical, and preferably not use it as for EK. It is a no-no, because if you just see the counts, it's 2800, more than that, young tissue, you would be tempted for that. But that's something, if you go by books and if you go by that, and right now I frankly do not argue with them. I agree with what they're writing, because technically they're right, and I was surprised that it was just not our eye bank manager, but there were major eye bank managers or the senior evaluators who agreed to that this should not be used for they grade it as that. So this was another 29, 90, 25 years with several stress lines and mild to moderate cell dropouts. Again, this tissue was graded as therapeutic by most of the evaluators who were there. So sometimes as surgeons, I would jump on this tissue when it comes to a therapeutic. I would always say, send me, because I know it's going to be good. So sometimes when there is a scarcity, and this is pre-COVID when you had the luxury. After that, I think we've become a little more lenient, and I said, no, I'm not going to go for therapeutic on this. We would better go in for that. This was one of the first trainings which we had on evaluation, and it was hosted by us there. By SightLife it happened, and this is where we came to know that it's not on surgeons anymore. It's better for the evaluators, who should keep on doing and keep on developing their models on how to distribute. This is the details of the cornea suitability. I think we are all surgeons here, so I think we would be knowing it. So now this was like what we had previously, but now with DMEC, the criteria for tissue selection criteria for DMEC is something separately we now added. We've added in the first one, and this is separately. And I liked Dr. Sunita's point that it's better to do a DMEC and prepare DMEC from MK media rather than doing from cortisol. It's much more looser there. This is one of the papers which we had published on tissue evaluation, and anybody interested can go through it. It just details on how it should be done and what has to be done. So I would just conclude by saying that a proper tissue evaluation and documentation is an important link between the eye bank and the surgeon, as donor cornea quality is an essential prerequisite for successful outcome of any corneal transplant procedure. So this is something which was there, and we have a very enthusiastic technician and evaluation team. And I would like to acknowledge Mr. Surendra Dikshit, who is the iBank manager, technical, and he's the one who's now teaching us how to evaluate. I used to evaluate very differently, but they are much more, I would say, knowledge-wise also, and they're much more clear of what they want to do. I think their good discussion with the other iBank managers and technicians, I think that's something which is to be done. And what Dr. Arvind had an idea that starting the across centers, if we start building up eye banking into the technical, more into the technical part, it will really help us all to gain from each other. So thank you.
Thank you, Dr. Manisha. This was a very comprehensive overview of the entire processes of tissue evaluation, including the nuances. Indeed, we also as surgeons do not go into the depth of the stress lines and the tissue dropout, the endothelial cell loss and dropouts. So that is something that we continually learn from each other. Would you also like to elaborate about any special measures during the COVID that your team had taken up for tissue during the tissue evaluation?
So I think we all learned, and we all learned from each other. I think I was giving a lot of calls to Dr. Sunita also, how are you managing and how we did. Definitely glycerine came up like a big boon for us. And I remember I called up Neeti right at night, how do you preserve? Because I had never preserved, and there was a lockdown which was already announced, and she said, steel ka dabba chahiye. I was looking for that steel ka dabba. How do I get it to the eye bank and get it autoclaved? Because from my place it was a different state. So they were not even allowing me to go there unless you get a specific pass. So I think glycerine tissues came out very handy. Secondly, when we were doing dissects and we were using the lenticule as well as the superior part, I think most of us have done that. And when we were doing the normal tissue also, which was distributed, the rim was kept, and that rim was used for other cases, for the patch grafts, for sclera. In our hospital, now we are not preserving sclera separately. We are now distributing it with the therapeutic tissues only, and we usually have that. Now we are not doing a glycerin, and our tube implant, like our glaucoma surgeons are happy with the newer system that we've been doing it for years now, 2-3 years. So when we realized that they did not needed the bigger sclera, they needed just the upper part. So where in a therapeutic tissue, if it's a good rim, so we send fresh tissue there. So that's something which we've been doing now. And so we are not now preserving, we do not have preserved sclera, and sometimes the plastic people are not very happy with it because they need bigger sclera.
So
yes.
I want to ask one question, like how sometimes I have a difficulty in differentiating stress lines from DM holes.
So stress lines are linear lines. They are very linear, and they are usually, I mean, it's more, you would say, like in Hindi we call it jharit padta. It's typically like that. Somewhere your cornea is just bent.
They both that is at the level
That
of
is also at the
endothelium.
level of
At the
endothelium.
endothelium,
Folds are more irregular, you would see vertical. This is more linear, which you would see. And they are like, they would just cover from edge to edge.
some of them would also have this kind of a picture,
Yeah,
some
sort
going
of,
vertically,
yeah.
some horizontally, so like a crisscross netting kind of an approach would be there. So the earlier tissue where the corneal edema was much more, just the penultimate before we discussed stress lines. So there the DM folds are very apparent. In fact, the sections that madam showed, that also showed very thick folds almost at the posterior stroma, and they were crisscrossing each other. Whereas the next ones, the last one was a classic one, where the entire endothelial cell loss was primarily restricted only to the DM, the Descemet's membrane, and perhaps that helps us to give some idea that the tissue had been wrinkled while extracting it from the globe.
And do we have clinical studies like to show whether if there are more stress lines, then what is the outcome of the transplant?
Clarify. So sometimes the problem is that when you talk about, when you say DM folds and stress lines, so in the presence of desmus membrane folds, sometimes you may not be able to see the stress lines because
Yeah.
it's just masking, because edema
Yes.
is kind of masking of stress lines. Stress lines sometimes are more apparent when the desmus membrane, like the, you know, you don't have much of edema, epithelium
Yes.
intact, so you'll see it very classically. The implication of stress lines is very, very, if you stain the cornea, you will see that. And
Yes.
particularly if you use these corneas for DMEC roll preparation, you will
Yes.
have a difficulty, because you will have a difficulty means you'll see a lot of staining of that cornea. So
Yes.
that cornea need not be suitable, because sometimes you see if there are too many stress lines, in those areas you see linear streaks which gets highlighted on trypan blue staining, and they may not be giving you adequate count post, because obviously the area where if the staining is right in the center, that area is devoid of endothelial cells. So that would be the implication of it.
And it is very
Too many
and
stress
you
lines
have
is
to
not
be
a
sure that they're usually focal at times also. You may not get diffuse stress lines. So if it is a focal on the peripheral, it's okay. You don't have to be very fussy on the peripheral one.
yeah. So
But
generally,
if it's in the central, then it's
yeah. Generally, you see quite commonly, like any corner you'll see some bit of stress lines in the periphery, and you stain, because for PK, you know, it will not matter so much. But if it's there right in the center, then yes, certainly yes, you may not want to use that corner if it's excessive.
Microbiology. You take out the cornea, take a like scleral button from there, take a small piece of sclera.
put it on the bladder.
So how many time you've got any organism?
There was one patient wherein the media color, and I was not sure, it was not yellow. It was not exactly red. So it was some sort of, you're confused. You're not finding it unsuitable. So there we cut it. We do it on the laminar like we do on the cross. Just cut it and we put it there, and then there was growth.
Yeah, color change anyway will not use, even if it is not grown.
Otherwise, when I mean, you're not doing it routinely. You do it. You just reserve it for those cases where you are dicey. That are we dealing with some sort of
Yeah, huh.
or somewhere your technician comes and say, "Madam, somebody saw that there's maybe a breach in somewhere." So you just want to double check that there's anything.
So in all those cases, no, in all those cases there is no growth. Wherever there is a slightest doubt.
Then if there is no growth, then you use it.
No, no, I'm asking how many times you got. No.
I'll check back how many times we have a register.
Uh-huh.
I don't remember anything very remarkable coming out of it. It's just to be sure that it's there. Sometimes you just do it for your sake. That
Safety,
you
yeah.
want to be safe. That okay. I mean, are you are sure that nahi aayega? It's very easy. You have an in-house microbiology. You just say culture, take it out. We send a lot, but we normally don't get. So whenever there is a doubt,
So you take for 48 hours.
as it is, tissue takes 48 hours. So
So you change it. When you take it, you change it to corneas.
we are taking post-COVID. What you are asking, change of practice, it's 100% cortisol. We are not taking any.
Or you are
tissue
collecting in corneas.
We are not collecting any tissue in MK. So that's what I was discussing. Because post-COVID, we decided if it was very less, we had to use every. And our utilization rate, as everybody's saying, ours also got very, like it was around 90% for a lot of months. And we are still maintaining that. So we are collecting 100% cortisol. So we need that 10 days buffer. And we are able to distribute at good space. So right now we are not using MK. That is our biggest problem right now when we got a solid stock. Because in stock we do not have MK because we were not using it, and now we are procuring. Yes, ma'am. Yes, sir.
What about the contralateral tissue? Would you be releasing it straight away, or you hold?
After cultures. Anything, we are very liberal in cultures.
Okay.
I mean, I would say in a month around 2-3 cultures we are definitely sending. Sometimes it's more. And during COVID times, anything which is even that contralateral, I was very, very important. So, but whenever there is anything which is not right, they say because you're not able to do whatever, anything is there. So it's you just send the bit for on a blood agar and you're sure legally that you do.
But only thing, the cellularity is in cornea. We are taking from
only in cortisol. For us, the practice never changed because initially we were always taking in MK medium because generally you find a placement within one or couple of 2 days time. So that's one factor for cost efficiency. And wherever we have a doubt, like what you said, we did this exercise long back to just evaluate the correlation. So what we were doing is we collect in the MK medium. Let's say if you have a situation where one eye, when one donor mate has a infiltrate and the other eye you want to keep, so we are not asking the technicians to do the scleral excision. What we do is we just take the primary MK medium from which the cornea was harvested and you send that for culture because even that will also grow. So we have done that study, but it was never a concord. We just did it as a part of an exercise and not taking really that parameter into account for transplantation suitability, but just doing it and just seeing what the pattern looks like. So all those corneas were transplanted. We did have organisms grow out of the primary culture medium, but it was never translating into infection post-operative. So we just did it as an exercise. But another thing you can, yeah, 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 yeah.
Just to leave, so let him finish this. Our problem with MK is cost. Because if we try, we get MK not free.
Yeah.
If we have to pay for that. So it used to be double cost for us.
Good afternoon once again. So in the next session we'll be discussing about the different tissue storage solutions and how that affects the way we have been storing our tissues and distributing them. Our objectives will be to discuss briefly about the historical importance, the brief description of the role of corneal storage media, and a classification based on the duration and types of storage. In the postmortem eye, once there is an arrest of aqueous humor formation, there is a depletion of nutrients, and then there is a depletion of the oxygen supply and damage of the corneal cells by gradual autolysis. So the corneal preservation aims to maintain the endothelial cell viability, prolong the duration of the storage, and prevent any infection during transmission. So when we aim to preserve the tissue, it should maintain the endothelial viability, maintain epithelial viability, allow assessment of the endothelial viability, maintain a clear thin cornea during the preservation time, prevent a lot of edema, ensure a sterility of the tissue, allow the transportation over time, allow cold chain maintenance, offer technical simplicity, and maintain the tissue suitability. In addition, it has to also be cost effective too. So the short term, intermediate, and long term, where broadly these are the following types of the media in which we have been storing tissues. So the short term up to 3 days was MK. Moist chamber is not 3 days, it's 1 day basically. And intermediate term is up to 2 weeks, and K-Sol, corneal storage medium, Dexol, Optisol. The top 3 are no longer used anymore. Optisol is what has been and the modification of which is Cornisol is what is being used now. The long-term storages is usually, apart from organ culture, renders the tissue non-viable. So cryopreservation, gamma irradiation, lyophilized cornea, and glycerol preservation, which we have been using, especially the glycerol preservation during the pandemic times. The moist chamber is mostly of historical interest, and sometimes where there is a very resource limited setting, then one may use that where in a moist chamber with a saline gauge, the whole eyeball is preserved and sent in a cold chain. The MK medium is what we mostly rely upon, and it allows storage for up to 4 days, and here the tissues have been stored with a good clarity and good transportation, ease of transportation, and also with good viability of these tissues. And sometimes we may need to transfer them to a long-term storage media such as the cornisol. And if we just break down each of the constituents of the media, basically the MK media has a tissue culture medium, and also it has a buffer with gentamicin, which is an antibiotic, and 5% dextran, which is the dehydrating agent and keeps the tissue compact. And there is an incremental change as we started developing into the different media. These are the K-Sol, where the dextran was replaced with 2.5% chondroitin sulfate, and then over that, when the cornea storage medium came, then in addition to 2% chondroitin sulfate, we also had the sodium pyruvate, the non-essential fatty acids, and some antioxidants. So this helped to reduce the oxidative lysis in the postmortem tissues. And then was the dextrol, where the Dexol, where a phenol red indicator was also added, and then in Optisol, which is what we know it now, has the minimum essential medium, which is the Eagles medium, the tissue culture medium 199, the buffer, the antibiotic, 2.5% chondroitin sulfate, and this was arrived at after different concentrations, both 1.5, 2.5, 3 and 5% chondroitin sulfate, and 2.5 yielded the best tissues, meaning there was a balance between dehydration of the tissue and compactness versus the edema that develops as the tissue increases in its storage time. In addition, some vitamins were also added, and dextran 1% was also added to the Optisol medium. Optisol was essentially a combination of Ksol and Dexol, and Optisol GS, which is the current form in which it is used extensively by the EBA, had an addition of 200 micrograms of streptomycin sulfate. The newer intermediate storage media are Cornisol, Life4C, Usol-C, and Shen media. They have been variably certified by the FDA. However, it's Cornisol, which is a modification of Optisol that has been widely used in Indian eye banks owing to the lower cost, good supply chain, and efficacy of 2 weeks storage of the tissue. The long term is not really used in either the American or the Indian eye banks. Organ culture is primarily restricted to the Australia, New Zealand eye banks and also to the European eye banks, and they incubate the tissue at 31 to 37 degrees up to 35 days, and there are means in which they evaluate this tissue regularly and periodically change the nutrients in which the tissue is stored, and there is a concern of tissue thickening and increased chance of contamination in case there is any breach anywhere in the process. The long-term processes are primarily the cryopreservation. The disadvantage of cryopreservation is that whenever we freeze the tissues fast, then there is ice crystal formation and disruption of the cellular organelles, which damages the cell, and when there is a slow cooling, then ice forms in the intercellular space, and when that happens, there is a loss in the osmosis, and the water is drawn out from the cells into the interstitial space, creating a solute injury, meaning that there is a high concentration of electrolytes inside the cell. So to prevent that, what was proposed was some cryoprotectants. These cryoprotectants are DMSO, glycerol, or propanediol, and the non-diffusible cryoprotectors are the polyvinyl pyrrolidone, starch, and certain sugars. What has been effective in our response, especially during the COVID, was the development of the glycerol preservation. Essentially, glycerol preservation is fairly simple: sterilized absolute glycerol 90%, and that is a media in which the tissue is stored. Usually it dehydrates the tissue, and the tissue is very clear, and before that a microbiology sampling is required to prevent any chance of contamination, though glycerol itself has per se antimicrobial properties as well. And once the tissue is there, it can be frozen at -4 or -20 degrees, and it's allowed to thaw, and then it's allowed to be soaked in the normal saline or the BSS, and then thoroughly rinsed, and then transferred to another bowl where it is kept and prepared before the surgery. Trephination is planned just like a normal tissue, but these tissues can be very tough to work with to start with, and then after that it is refined and transplanted. So this is how the procedure progresses. Colorimetric indices have been added to the media, and usually the normal pH is pink, but when it turns acidic or alkaline, there is a color change to yellow or red, and this indicates that there is a growth of microorganisms. These are some of our experiences with the tissue media. So the second publication was after Dr. Neeti's publication on the glycerol, her experience with glycerol, and this was our intermediate outcomes of therapeutic PK for the glycerol preserved using the glycerol preserved corneas. and our recent publication on the overview of short-term and intermediate-term cornea storage solutions. So all in all, the functional status of the endothelium and sustained corneal degeneration after corneal preservation are of great clinical importance, and they contribute primarily to the success of the surgical outcomes. So most intermediate term corneal storage solutions are efficacious. However, at present, long-term media are associated with poor endothelial survival and are also technically complex. Thank you for your patient hearing. Thank you. Yeah, with your permission, I will also go ahead with the second presentation too on the use of amniotic membrane and sclera. So the amniotic membrane has a basic anatomic structure of a basement membrane with epithelium on one side and a compact fibrous layer on the other. This has anti-inflammatory, anti-fibrotic, anti-angiogenic and antimicrobial properties. It is transparent, lacks immunogenicity, and behaves as a substrate for the growth and migration and adhesion of epithelial and corneal and conjunctival cells. So this is how the tissue is prepared. After all sterility, or rather after all the serology, the selected tissues are first washed off, and it needs to be processed within 12 hours. After thorough saline wash to remove all the blood clots and any extraneous tissues, the amnion and the chorion are separated. All tiny bits of fibrous tissue are removed from the amnion. And it is thoroughly cleaned, making sure that we do not tear the membrane. Cellulose acetate paper or nitrocellulose paper is attached to one end, and it is placed in the DMEM medium and stored at -20 before being sent for utilization. There is an extensive use of amniotic membrane in ophthalmology, both in cornea, conjunctiva, normal saline. Yes. Yes, yes, and negative serology. The sclera is another interesting tissue that is also used as a tissue for distribution from the eye bank. The sclera has a avascular rigid structure of dense interwoven collagen. It consists of episclera, scleral stroma, and lamina fusca. It provides a strong framework for the structures of the eye and resists any fluctuations in the intraocular pressure. It provides a resistance to the fluctuation in the intraocular pressure and also provides a pathway for the outflow of the aqueous. And it provides an attachment to the extraocular muscles and ciliary muscles. How do we prepare the sclera? This video describes in brief the methods in which the human sclera is prepared. It's first important that apart from all the contraindications where we do not do a cornea transplant from those donors, we do not take the sclera as well. And then in the biological safety cabinet where the sclera has to be prepared. And there is no audio here. A sterile wipe is given, and within that sterile drapes are placed. All the time we ensure that there is complete sterility. The eyeballs are also transferred into the sterile cabinet, and partially opened bottles of absolute alcohol are also placed here. All the instruments that are required for retrieval of the cornea are also used in preparing of the sclera, and these are also typically present in the eye bank technician's kit, and they are sterilized prior to use. The records of all the sterilization are also maintained. These are sterile aluminum foils. They are covered on top of each of the containers to ensure that there is no seepage of fluid, and also there is no touch and accidental touch or loss of sterility while handling the bottles and the tissue through which is now being processed. The entire uveal tissue is cleaned out using a spatula, and it's always best to remove it in toto. The excess fibrous tissue, the adhesions of the extraocular muscles are also removed. Then it is soaked in normal saline, and any other adherent fibrous tissue is also meticulously removed from the sclera. The sclera is then excised into 4 pieces typically, and then allowed to soak into a gentamicin solution. The gentamicin is 1:10 preparation of commercially available gentamicin. So 5 ml of gentamicin with 45 ml of normal saline is prepared, and it is soaked. This is the gentamicin solution being prepared for the antibiotic soak, and all the cut sclera ends are placed into it. After the soak, the tissues are taken up and placed on a sterile pad to dry out, following which they are transferred into absolute alcohol vials before being released. Some eye banks also have the method to store the tissues for 6 months before release, and some release them immediately. After preparation, usually the typical time of storage for the scleral tissue is 1 year. There are different methods in which the sclera can be preserved. So what is commonly used is the absolute alcohol in our eye bank, but some eye banks also send out fresh tissues. In addition, glycerin, gamma irradiation and freeze drying are also possible ways in which we can preserve the sclera. Sclera again has multiple uses in ophthalmic surgery, primarily in the glaucoma filtering surgery, but slowly there are different alternatives that are coming out, and even the cornea is also used as an alternative to sclera in ophthalmic surgery. Thank you for your patient hearing. Now I would like to invite Dr. Sujata to chair the session.
So we have 2 more talks. One is mine, antifungal in preservative media, and then Sunita will present about pre-cut tissues. So Arvind has shown all the constituent of preservative media. All of us know we have in Optisol, Cornisol, all we have antibiotic, no antifungal. But in organ culture media there is antifungal already. So whatever I am describing, most are like people are still doing experiment. It is not commercially available in Optisol. But we know because of the lamellar surgery, the keratitis mostly due to candida, it has grown. It is increased from 0.014% to 0.023%, and most commonly it is candida, and that too lamellar surgery. So why it is more in EK compared to PK? Because there is a more processing and additional warming period, and lamellar interface is more challenging to treat because fungus stays in the interface, more difficult to diagnose and more difficult to treat also. If you see culture positive fungal reams per 12%, in cases with candida, 14% cases with positive ream culture can develop clinical infection. So there is always a need to add antifungal in the media. If you see PK and EK, then maybe the bacterial, especially in our country, bacteria is more compared to fungus. But if we see only endothelial keratoplasty, and if you compare whole Western and whole world, then fungal. But in our scenario, if you bacteria is more. So coming to optical GS, there is streptomycin and gentamicin. MK media only gentamicin. In organ culture, there is amphotericin B. So fungal recovery rate in antifungal supplemented organ culture media is lower than non-antifungal supplement. So both voriconazole and amphotericin B has been tried, but nothing is like everything is all publication stays. Nothing is added. Maybe one is septi efficacy has been tried, but dosage also has been decided. I feel the one is cost, because cost and when to put and how long is stable. And so what is the dosage and efficacy? Any drug, there will be efficacy and safety profile. So in this study, the voriconazole was added in optical GS, and you can see the 7 out of 533 cornea were positive for fungal organism in plain optisol, whereas when it is fortified with voriconazole, there are no reams which are positive. There is no difference in cellular morphology, so that means it is not very toxic also. But this study again says that candida, they have taken only candida and candida glabrata, so no growth in amphotericin B supplemented 5. Whereas in the previous one it was voriconazole, and this endothelial toxicity when you increase the concentration. So you need to find a dosage where the efficacious but least toxic. We did a similar study in MK media where we took 5 concentration. In fact, we saw first day, 4th day, 7th day, but wherever it went to reviewer, they asked the question, if the MK media is for 4 days, why do you check it 21 days? So we removed those part and published. But the main idea is that when you collect cornea, you can't keep on adding everything. If the drug is there, then you have to see for 1 year. In fact, I wanted to see the stability of the drug I went for HPLC, but then I stopped the idea because all the reviewer, the question was, why do you check at 21 days? So here also we took 3 because candida is not the most common organism here. So we tried Aspergillus, candida and fusarium. Again, we found amphotericin B significantly reduces fungal contamination. Even the cost wise also, amphotericin B is cheaper than voriconazole. So you can see the amphotericin B concentration the lowest, and day 0, you can see here candida albicans in 20 microgram, it is 0 in day 4, and even the 2 microgram also it is 0. Whereas in voriconazole in 100 microgram on 4th day it is 0. So these are the published studies where they have, the first one is voriconazole, but there is the significant reduction in positive ream culture, there is no endothelial toxicity. Whereas the another study, they have amphotericin, they found significant reduction, whereas voriconazole no. And it is higher concentration, there is endothelial toxicity. We found amphotericin B is superior superior to voriconazole. We are yet to publish the endothelial toxicity. So what is the optimal concentration? This study says that for candida albicans, the concentration is more than 1.25 microgram, and 2.5 reduces more than 90% after 6 hours of cold storage. So this study, they've added at different points. One group did not add anything. The first group they've added when they get the cornea. The second group, it is like they simulated a situation where it is a dissect. So when they prepared the dissect lenticle, they have added second time. The third one, like one group got twice when they collected as well as they prepared. One group did not get anything, one group got only when they collected. So finally the conclusion was where you have added twice, that efficacious is more. So in 0.225 microgram is effective, and we add twice. So basically we need antifungal, there is no doubt in that. And amphotericin is more effective than voriconazole for candida. We got in all for Fusarium aspergillus also amphotericin is more effective than voriconazole, and 2.5 microgram or amphotericin is safe and effective doses. But probably this is not, maybe you need regulatory to add anything new, and cost. When do you add? If you add during preparation, then it is cheaper rather than adding every time when you collect the cornea. And then how long it will stable. You need to stability also, that the solution is stable, that concentration is stable till the 1 year and the end of 1 year shelf life. But some people may finish, but those who keep the media for 1 year, the drug should be stable in that. Yeah, the level for 1 year. That's why I wanted to know whether 3 months, 6 months. But the reviewer is so, almost all reviewer asked, why do you do till 21 days? If the MK media is for 4, tissue can stay for 4 days, why do you check it? No, I did not check stability. I wanted to check the efficacy. But the fungus almost died due to cold temperature also. Because most of the 21 days it is working. Whereas tissue is used in 4 days. So Sunita, you can... Those are not tissue, those are the organism were there, then we add. Tissues are in the lab. Yes. It was in the lab. And the media was stable.
Morning you connected.
Media we have put the organism and then we took cultured it, then it is going. Then the colony count was compared to 0. What percentage reduction?
All right, so I think we'll come to the last talk of this session. This is on pre-cut donor tissue, pitfalls and benefits. So we all have, majority of us have moved to pre-cut, which is provided by the eye bank, but some instances are there where we ask for manual preparation, which is primarily done by the surgeons alone. This is just a video just to show how the manual preparation is being done and the automated preparation. So what difference one will happen is that in the automated pre-cut, we have dissection which is limited to the central part, central 9 to 10 millimeters, whereas in the manual dissection, you have a dissection which is right from limbus to limbus. This is important for certain selection criteria between the two methods. So DSEC pre-cut can be done by both the methods, and the advantages of pre-cut, which is done by the automated process by the involving the eye bank team. The various advantages I would say are, one is that it reduces the surgery time for the surgeon. The interface is far more regular and there's lesser risk of donor loss compared to manual dissection, which can happen because of variations in the tissue, and hence this is more predictable. The one disadvantage of pre-cut automated compared to manual would be the cost involved in the setting up the pre-cut lab, and the warming cycle is introduced because pre-cut mandates you to do a specular before and afterwards, because the end user may be slightly different from the primary place where it is being done. And the second and the third thing, which we already discussed in the DSEC manual preparation, is about the centration. In centration, it is important because the manual dissection is from limbus to limbus, whereas the centration is very important for the pre-cut automated because smaller area relative to the manual dissection process. Now I'll be covering this talk into 4 headings: the pre-cut assessment prior to surgery, which is of relevance to the surgical outcomes; pre-cut preparation for insertion and imperfection which can happen in the pre-cut tissue; and handling inadvertent issues during the preparation. So this is how the pre-cut donor looks like when we get in the eye bank. So it will be in the viewing chamber with the cornea mounted in the guard in the center, and there are 4 marking dots available to know the centration within which you have to be while trephination. So pre-cut donor assessment in the operating room should include looking into the donor parameter, donor form, which includes the parameters such as pachymetry, graft diameter, pre and post-cut endothelium, which is done as a protocol, and pre-cut preparation to surgery time interval. This is also relevant, and gross examination of the pre-cut tissue to identify the centration marking dots and the anterior lamellar cap, because quite often if the preparation time and the utilization time is different, the anterior cap may be missing, which is of relevance because the cap does not stay there for long, and sometimes if a longer preservation has been done with the pre-cut, then the centration identifying marking dots may become faint to know the exact centration of the tissue. Now, I will say this is very important to look into the graft thickness and graft diameter. This is because one needs to know what kind of tissue we are implanting in what kind of a recipient. So, certain times if the graft diameter is small, then you have to be within that area of the graft diameter. And thirdly, graft thickness is essentially very important to look at because the handling of the tissue, the ease of the tissue handling will depend on the graft thickness. Sometimes if the cornea is the pre-cut tissue, because there can be some variations. If it is thinner, there can be handling issues, or if it is thicker, then you can have other issues related to the graft thickness. So this is one study where we looked at the pre and post-cut endothelial cell density in the pre-cut corneas, which are prepared by the eye bank technicians. So this is on the basis of 1049 pre-cut tissues which are prepared by two primary eye bank technicians. So there's a good correlation between the ECD between before and after cut, and this scatter plot shows that. What about the pre and post cut endothelial cell density? Now there is a variation both towards up to around 500 cells per millimeter square on either side. It can appear lesser, it can be on more side. This doesn't mean anything to do with the overall corneal assessment, but then we need to understand the specular microscopy is dependent upon the optical principle of the imaging tool. So quite often the image clarity gets better during after the pre and post cut, and that could account for these variations which occur up to the tune of 400 to 500 cells per millimeter square in individual corneas. So one needs to be mindful of that. Certain times we'll get an issue like this one where the pre-cut graph shows before the cut you have a good morphology, and post-cut count you are not able to image the cells. Now this can typically happen in very younger donors where the tissue is very elastic, and because of the same reason that you're not able to mount it well and not able to get the image focused, you may get an image which is completely distorted, and you may not be able to capture the endothelial image in the post-cut period. Now what does this mean? Should we discard these corneas? Should we utilize these corneas? Now this again is kind of subject to variation. If there has been no protocol deviation from the eye bank side and the technicians you have confidence into, and no mishaps happen during the pre-cut tissue preparation, one would be okay to use these corneas, and we have used these corneas. Personally, we have had experience in using these corneas, sometimes because you don't get, for various reasons, the post-cut count. So having utilized those corneas, the corneas do recover as long as you are sure like there was no issues, you can certainly use that. Now, what about the pre-cut graft thickness? Now, there can be a lenticular thickness variation because primarily the way you apply this force upon the microkeratome, there could be certain deviations in the posterior lamellar thickness, and this table shows that. So, less than 100 micron thickness was seen in 0.5% of the tissues amongst those 1049 corneas which were done for pre-cut, and between 101 to 150, between 100 to 150, majority fall in this category. 56% were with this posterior thickness of this nature, and between 151 to 200 there were more than like 40.3%, and more than 201 were a very small percentage, 3% had that, and these corneas were all utilized. Now these are two things. The tissue, when it is too thin, it may not have a very good memory to retain its shape. It behaves almost like a DMAC roll. So one needs to be cautious about these corneas not to lose the polarity and the right orientation. So what should one do is one can mark the corner to get the right orientation. Thicker grafts are okay to use, they don't cause any issue, but they may just take a little longer time for corneal graft clarity to recover, and they can sometimes account for a little bit of an hyperopic shift. So what are the effects of transportation and long interval between the pre-cut and the surgery time? As such, no effect on the endothelial cells, but the 2 points which we discussed earlier was about the anterior lamellar cap dislodgement that can occur in longer preservation, and centration mark dots can become a little fainter, which one needs to be careful about while trepanation. The recipient parameters relevant to pre-cut preparation, the sizing of the graft is important. So here I'll say corneal biometry of the recipient, where you assess its horizontal corneal diameter and the vertical corneal diameter, because this would be relevant to plan the sizing of the graft. And anterior chamber characteristic, this will determine what kind of sizing you would want. Now this is again important, like if you want a larger size for some cases like buophthalmos where the corneal dimensions are more, you would not want to use a pre-cut tissue because your approximate corneal diameter of 8.5 may not suit a buophthalmic eye. You may have to use a manual dissection where you can have a little larger dimension to the tune of 8.5 to 9 millimeter size. So these will be the individual characteristics to look for when to go for automated. Majority can be managed with automated method, but some instances you may have to use a selective manual preparation method. So ultra thin corneas, marking and staining the DSEC graph can help, and these could be situations where you have the thickness of the lenticule very thin, less than 100 microns, and where the recipient is very severely hazy cornea. Those kind of things again will require staining of the cornea, and also particularly those cases of optical graft where the graft host junction is opacified. So sometimes you cannot make out the sizing. So one of the methods to identify the lenticule would be to stain the cornea. Now this is just to run through the steps of the pre-cut, handling the pre-cut. So you have in the viewing chamber. So you pick it up with the LIMS forceps and dry the bed because there will be some corneal storage solution. Put it in the block and make the centration clear, and the holding trephination holder is kept in place after centration, and then adequate size trephine which you have planned should be used with a proper centration. And there could be certain imprecisions in the pre-cut, and these cannot be completely overcome. This is mainly because the pre-cut is an automated method and may have some variation based upon the strength, the force we apply during the pre-cut process, during the running of the microkeratome. So sometimes the pre-cut can have non-uniform posterior lamellar bed thickness, and it can be non-centric and it could be non-circular. So these do not have a major deviations, but sometimes can have minor refractive hyperopic shifts can occur because of this reason. Ultra thin tissues again can be done by double pass method, which can lead to less cell loss, because each time you pass the microkeratome across, and if you have a double pass, you will be contributing to a certain degree of endothelial cell loss, which can occur because of this reason. Microkeratome, the ultra thin can also be prepared by slow pass technique if you run the motor in a slow motion, or versus a head size. And there can be two methods of doing this. Now, if you with the slow pass technique versus head sizing, you can have greater variations in the graft thickness overall. Now, this is just to show, like in this particular case, the centration was exactly precise. So you can see a rim like this. This is basically the cut has passed right into the center, and you have a ring. So one needs to be mindful of this kind of attachment. This ring can be easily pulled off, and understanding how the pre-cut has gone into the tissue, the trephine has gone into the pre-cut tissue, is important to recognize this. One more video just to show, like certain times, even if you center it, there could be some concentric stromal tissue, which is from the anterior lamellar bed. Now here also you see the ring, what we saw in the previous picture was complete. Here it is only partial. So when you release it comes out as a concentric shaped stromal tissue. So in summary, I'll say pre-cut tissue is very easy to be learned and can be easily handled by the eye-bank personnel. But familiarity with using the pre-cut tissue will help in better handling and avoid tissue wastage at the time of surgery. Thank you. Yeah, I think we can. Dr. Sujata, any comments? All right. I think it was a nice session, and I think all talks were very relevant, and enjoyed it from everyone. Thank you.